Hello, my name is Jeffrey Lee. I am an internal medicine PGY2 at Huron Valley Sinai Hospital. Today I will be going over a clinical vignette titled Double Trouble, a case of gastrointestinal stromal tumor and urothelial carcinoma. A primary tumor is the origin site for any malignancy. When multiple tumors are found, histology is the main modality to distinguish between metastasis and a second primary tumor, or SPT for short. The criteria for diagnosing an SPT are that each tumor must be confirmed histologically. They must be separated by non-malignant mucosa and distinct from each other, and the probability of metastasis from one tumor to the other must be excluded. In this case, we have a 64-year-old male presenting to the hospital with complaints of abdominal discomfort and left lower quadrant pain with eating. Pertinent past medical history is that he is a former smoker with a 20-pack-year history of tobacco use. CT scan revealed a large mass with intrinsic necrosis within the mesentery. Biopsy confirmed diagnosis of a low-grade gastrointestinal stromal tumor, or GIST for short, and subsequent KRAS testing revealed a mutation in exon 11, with susceptibility to imatinib and sunitinib. The mass involved the second through fourth parts of the duodenum and extended to the mesentery of the retroperitoneum and down towards the aorta. The lesion was fixed to the large vessels prohibiting safe resection. He was started on neoadjuvant therapy with imatinib, but eventually switched to sunitinib due to insurance reasons. Months later, followed PET scan led to discovery of a new area of tissue abnormality within the urinary bladder. He underwent a cystoscopy with transurethral resection of bladder tumor, which showed multifocal bladder tumors. Initially, these were thought to be metastases from the GIST, however, biopsies revealed a high-grade, non-invasive urothelial carcinoma. He was subsequently started on BCG intravesical immunotherapy and continues treatment to this day. Multiple primary tumors are not uncommon. Epidemiological studies have shown incidence rates as high as 17%. When multiple tumors are found, the main concern and challenge is how to treat them both appropriately, finding a treatment regimen that would adequately treat both malignancies effectively while keeping drug toxicity at a minimum. There are many factors that correlate with development of cancers. The most common theory is the two-hit effect, a hypothesis proposed by Alfred G. Knudsen in 1971. This hypothesis states that most tumor suppressor genes require both alleles to be inactivated, via mutation, epigenetic silencing, etc. Essentially, a patient who has a mutation in one allele at baseline has a higher chance of developing cancers with multiple origins. In terms of GIST, meta-analysis done by Petrelli et al. Have shown a 20% risk of developing SPTs. This value may be underreported as small GIST could have been missed in asymptomatic patients found to have other malignancies. Studies shown that colorectal, prostate, gastric, esophageal, lung, breast, lymphoma, and kidney malignancies were the most common SPTs that developed alongside GIST. Another population study done by Murphy et al. Corroborates this finding by finding an approximate 17% additional risk of SPT in patients with GISTs. The prevalence increasing with age. This study also showed bladder cancer being one of the malignancies with increased risk. This study also factored in GIST being the second malignancy that developed after being diagnosed with the first. This population study showed a temporal relation and increase of separate malignancies both prior to as well as after GIST formation. There are multiple factors that can contribute to development of SPT, but the exact mechanisms still remain elusive. Common risk factors include gender, age, hereditary risk, diet, and environment. Even advancement in treatment protocols and modalities have a part in increasing lifespans of cancer patients. This leads to more time to develop a secondary malignancy. Unfortunately, due to low incidence and prevalence of GIST tumors, there is not enough information to determine mechanisms that cause an increased risk of SPT in this specific population. This is especially the case for development of urothelial carcinoma after a diagnosis of GIST. This case provides more information and reason for further research, and provides awareness for physicians to be vigilant for histologically different malignancies in their patients who have cancer.